You can tell Peter that Bob failed.
I didn't.
that
I didn't.
Aw, dang.
So we, I was feeling caught up, so I don't have material to teach. We could go over the problem set, you know, the diuretics, and what I was looking for there. We could go over this slide, which is sort of a summary of where we were at the end of the day on Tuesday. We could play these games. We could play games like this, right? What is clearance? I've got a whole set. What goes in the boxes here to describe sodium reabsorption? What goes in the boxes here to describe glucose reabsorption? What goes in the boxes here to describe bicarbonate reabsorption? I can do it for, you know, we can talk about the leukopenline. We can talk about control, which we did, or I've got a set of clickers at the end. I don't have a strong feeling about it. So I would like your guidance as to what you would most like to do as part of the learning process for the exam. Remember, this is preparation for the exam a week from today. On Tuesday, we will jump the gun and start the digestive system. That will not be on the exam. Games, the fill in the blank games. Okay, let's do that. Okay. So this laser is still working. You chose. You get to go first. I'm going to save time by not writing. Would it be better if I saved time by not getting up on the chair and trying to write in the boxes, or would you? I mean, if we just say, yeah, put, you know, X in that box, is that good enough? Which would you prefer? Let's try it without me getting up on the chair to write the words. Okay. This here is referring to the renal cortex. Good.
Could we label parts that are not in box?
Sure.
So,
You want to point to something and give me another name?
so the outer layer is the capsule.
Good. Outer layer is the capsule.
That's the renal vein.
That's the renal vein.
That's the renal pelvis.
This would be the renal pelvis.
Those are the calyces.
Calyces, major and minor calyces. The ureter. Ureter. Not the urethra. Not the urethra. The ureter.
There you say,
Hmm?
there you say the veins.
We already said the veins, the renal vein. That one was already taken.
What is it?
I'm sorry.
What hasn't been said yet?
Oh, I don't know. If I tell you, you'll know. Just pick one.
What is this one?
That's the ureter.
Yeah, we just
Ureter. This is the renal cortex. So what's this? Or what's this?
I know the vein was the bottom one, the top was the artery.
Yeah, the renal artery. This is the only one left.
The
Medella.
Medulla?
The medulla.
That's correct.
That
Medulla
sounds
is-
like the
I don't know.
armadillo.
Medulla is correct, medulla is also correct. What's another name for this?
Pyramid.
Pyramid. What's the name for the thing between the pyramids?
Pyramid.
Renal column. What is the name for this sort of space here?
Helium.
The sinus?
What does this use?
Good, okay, so I think we're done with this. Oh, yeah, right. What's this little nipple here at the end of, at the inside end of the renal pyramid? Papilla, renal papilla.
Yeah.
Sure. Okay, you're good at this. I don't know why you
Bella
wanted to play this.
papilla.
Hey.
Um, So let's do this one,
Cortex.
okay?
That one. Bowman's capsule.
Okay.
The collecting tubule.
Collecting tubule, good.
The distal tubule.
Distal tubule,
Bowman's capsule.
we did the capsule, and so Bowman's capsule is the outside. What's the thing just inside Bowman's capsule?
Glomerular cell.
Okay, glomerulus is inside, and between the glomerulus and the capsule is
Bowman's space.
Bowman's space. What are the cell types that make up the glomerular capillaries? Podocytes. Yep. Loop of Henle. Let's see if we can figure out which is ascending and descending. So there's, so to figure out which is ascending and descending, you have to try to find the proximal tubule. Oh, okay, proximal tubule, and then descending and ascending limb of the loop of Henle. Vasa recta. Medulla.
Medullary collect.
Okay, medullary collecting duct and the cortical collecting duct, yeah. Fair. Well, okay, so these lines here, so this line is going to here, and so is this line. So I think this box would be filled with peritubular capillaries. It's not, but you're right, this network of capillaries, the red and the blue things, is the peritubular capillaries, and this network of capillaries is the vasa recta. Okay? Turn it around again. Well, maybe I'll start pointing out things.
Okay.
Well, go, you choose one.
This little elbow is the macula densa.
The little elbow is the juxtaglomerular apparatus, and inside the distal tubule here is the macula densa. What else? Okay, look, what is this? Somebody just shout it out. What is this? A branch of the renal artery. And what is this?
Afferent arterial.
Afferent. And what is this?
Efferent.
Efferent arterial. Same thing over here. Afferent arterial, efferent arterial, juxtaglomerular apparatus.
Yeah.
Okay, so you know the answers? You guys, so we kind of already did this, podocytes. So let's skip this one.
Yeah.
Yeah. We kind of already did this. So this is what I was illustrating. The macula densa are the cells of the distal tubule that make this contact with the juxtaglomerular apparatus. Okay, let's clear. Who wants to tell me the equation for clearance? I'll write it on the board, but not in the box. Anybody? Max.
Cx is equal to v times ux over dx.
Okay, unpack the abbreviations.
Right, the Cx is the total clearance
Clearance of,
of whatever substance.
Whatever.
Yeah. V is the urine flow rate.
urine flow rate in mils per minute. You might have to divide by 1440 if I give you mils per day, because there are 1440 minutes in a day.
Ux is the urine concentration of the substance.
Right.
Px is the plasma concentration of the substance, and they
Okay.
can be in n units as long as they cancel out.
Right, so they can be, if these units are the same, they cancel out, and we're good. If they're not in the same units, you've got to make adjustments until they're in the same units so that they cancel out. Another formula, so what if we wanted to replace this with another thing? What would we put there? EL, excreted load. And as long as we're putting up that, what is the definition of FL, filtered load? GFR times PX, right? And how do we measure GFR? Exactly, clearance of something that is filtered but not reabsorbed. That is freely filtered, fully filtered, but not reabsorbed or secreted. Okay, so you guys got that? Do we want to play the game here? Okay, this is a game we haven't played before, so let's play the game. Okay. There's two ways for me to play the game. One is for me to point something out and for you to give me a name, or for you to just put something in the box. Josh, you want to?
In D, for the first box on the left
Oh,
is
okay.
the sodium K plus 2Cl code transporter.
In D,
In D.
the sodium potassium 2-chloride cotransporter would not win you any points.
In D.
What goes in here? ENaC. The epithelial sodium channel goes in here. And this is that sodium potassium exchange, quote unquote, mechanism that I asked you to refer to in the amiloride question. Okay, you can go over that if you want. What goes in this box?
Sodium, potassium, ATPase.
Sodium, potassium, ATPase, which goes in this box, and this box, and this box, and this box. Okay, somebody else pick one and give me a name. Okay.
The top one in B on the apical membrane is the sodium potassium chloride.
Yes, the sodium in the thick ascending limb, here is the sodium potassium 2-chloride cotransporter. Good.
Right there
Yeah.
and right there are the sodium and proton antiport.
Sodium proton exchanger. Pretty sure that's right.
Yeah.
Somebody's looking at the answer sheet. Sodium proton exchanger would go here and here. And what were the clues there? Well, we can see water being broken down into hydroxyl ions, so what's going off of this branch right here and what's going off this branch, that's a proton, and so it makes sense that this is the sodium proton exchanger. Okay? Anybody else wanna pick a box and label it? So what goes in this, what goes in this box?
Sodium bicarbonate transporter.
A sodium bicarbonate co-transporter. Here is the chloride bicarbonate exchanger, which probably is also expressed over here, but this is a sodium bicarb co-transporter. And I think that's what this bicarb is supposed to be drawing, we'll see when we open up the next slide. Okay? What goes in this box? So we said that in this box is the sodium proton exchanger. And what goes in this box? What is it?
Sodium glucose transporter.
Sodium glucose co-transporter. That's very well done. Now, I forgot that that's what was in there. That is the correct answer, because there's the glucose uniporter for glucose co-transporter. So from sodium perspective, this is sodium glucose co-transport. This is sodium proton exchange. This is the pump that establishes that sodium gradient. And this is the sodium bicarb co-transporter. Okay, did we do this one? Yeah, we did. That's the sodium potassium 2-chloride co-transporter. We did this one. What goes in here? A sodium chloride co-transporter. It is similar to, but different from, the sodium potassium 2-chloride co-transporter. Similar concept, different protein. I think we're done, right? Are there any boxes we haven't covered?
This is not a box necessarily,
Yeah.
but, on the, like, list of things we needed to know,
Yeah.
the key concept list, there was something about, how in distal convoluted tubule, there's like a potassium, like something about potassium in all of the slides we received, like there was nothing about.
Okay, so delete it from the
Okay.
key concepts. This is, potassium is really important. But I'm trying to simplify things, hopefully not to the point of being, misleading. This is the potassium transporter that I want you to know. So, there's sodium. Yes?
Said that water follows sodium.
Yeah, so especially here in the proximal tubule, where we have a leaky epithelium, water flows paracellularly as sodium is pumped transcellularly. That happens in the proximal tubule. That does not happen in the ascending limb of the loop of Henle, because it's a tight epithelium. There is minimal water flow in the distal tubule, and there is variable, vasopressin-dependent transcellular water permeability in the collecting tubule. Okay, let's do glucose. We kind of already did it, but what goes in this box? The sodium glucose co-transporter. The hint is right there, SGL. Sodium glucose co-transporter. What goes in this box? Or one of these two boxes, you can't tell which is which. The sodium pump goes in one of them. That creates the sodium gradient. And what is in the other box? A glucose passive uniporter. And it's the same in both the early and the late proximal tubule, except that the details are different. The concepts, which is what I want you to know, are the same. Jay, do you have a question?
Did you say that the top one was just a sodium channel, or did I mishear you?
It's not a sodium channel.
It's an NAK ATPase, right?
This is the sodium potassium pump.
Yeah.
Yeah, and the ATPase.
Okay.
Yeah. This is the sodium potassium ATPase that pumps sodium out creates the sodium gradient that is used by the sodium glucose cotransporter to pump glucose in. And then glucose is pumped in and then flows downhill in the basolateral membrane due to the glucose uniporter. And it's true in the early tubule, early proximal tubule, and in the late proximal tubule, but the details, the name, the type of the sodium glucose cotransporter is different. Its affinities are different. Let's not get into the similar differences. They're highly similar, especially at the conceptual level. Okay. Bicarbonate reabsorption. Okay, let's do this as volunteers. How do we begin here? There's two ways to begin this story. I prefer to begin it here. What do we need to think about here at this beginning? In the tubular lumen, what do we begin with when we're talking about bicarbonate? Bicarbonate, filtered bicarbonate, right? Bicarbonate is a solute in plasma. You probably want to know a rough estimate of the concentration of bicarbonate in plasma, because we talked about it in the respiratory unit. 25, 26 millimolar is a reasonable concentration for bicarbonate concentration in plasma. It is small, it is freely filtered, so we would have 25 or 26 millimolar of bicarbonate filtered into the tubular fluid. Okay, let's follow this pathway. So here's bicarbonate. Here is, what is this? Carbonic anhydrase that is expressed on the apical membrane, and its active site is exposed to the tubular lumen, so it catalyzes this conversion of the bicarbonate that is in the tubular lumen. Converts it to water and carbon dioxide. Carbon dioxide is freely permeable everywhere. It's permeable in all membranes, so carbon dioxide flows into the cell. Well, this cell is the same as this cell, so this carbon dioxide is inside this cell as well. So what goes in this box? Carbonic anhydrase, a cytoplasmic carbonic anhydrase. So carbonic anhydrase is both inside the cell and exposed to the luminal fluid. It's not flowing with the luminal fluid, it's bound to the apical membrane, but its active site is in contact with the luminal fluid. Two forms of carbonic anhydrase. And I think when in the carbonic anhydrase question, I might have asked you to have indicated that you knew that, and that by inhibiting carbonic anhydrase, we're inhibiting it here and here. With things like diamox or carbonic anhydrase inhibitors. Okay, so there's the tip of an arrow there, proton. What goes in this box here that is going to take a proton here? The sodium proton exchanger, we've already talked about that. And what else? A proton pump, a proton ATPase. Both of those are active transport. Sodium flowing down its concentration gradient, pumping protons out. A primary active transporter hydrolyzing ATP to pump protons out. So that's what's happening here on this apical membrane. What goes in this box here, which is referring to the bicarbonate? The chloride bicarbonate exchanger and the sodium bicarbonate co-transporter. And that moves bicarbonate from the cell into the peritubular space, where the peritubular capillaries are ready to take it up. Okay, so we've got everything covered here? Yeah. So now let's talk about diamox for a minute. And I think most of you got this figured out pretty well. The idea here is that by inhibiting this carbonic anhydrase, it's pretty straightforward. We inhibit this carbonic anhydrase, we don't convert bicarbonate into CO2 as much, and so more bicarbonate stays bicarbonate in the urinary fluid and is excreted as bicarbonate. That's pretty straightforward. An excretion of bicarbonate, why is it we want to do this? Well, in the setting of hyperventilation, let's just do this. I feel justified if asking you to draw up a Davenport diagram again. Might not be worth the same value that it was worth in the last exam, but sure, why not? Bicarbonate concentration, blood, plasma, bicarbonate concentration, millimolar, 26 millimolar, blood or plasma, pH, 7.4. Here's where we start. We're on this curve, which has a PCO2 of 40 milliliters of mercury. Okay. Hyperventilation. Respiratory alkaline. Going to a new curve with a PCO2 that is lower than 40 millimeters of mercury, because we have hyperventilated out more CO2. So now you knew from before that the renal compensation for this was to go that way. Now you know why the kidney, or at least part of why the kidney, can excrete more bicarbonate, lowering bicarbonate concentration to 20 millimolar in an effort to renormalize blood pH. One of them is this arrow is increased excretion of bicarbonate, so that the plasma concentration of bicarbonate is lower. So now you know one of the mechanisms for increased excretion of bicarbonate, to either use a drug or use, changes in expression of carbonic anhydrase to lowered carbonic anhydrase activity, either by a drug or by expression, will decrease this rate, will increase the excretion of bicarbonate, which is what we're trying to do. And that's why diamox can be used in the setting of altitude sickness, to help the body do what it would do otherwise, but help it do it sooner and faster. Okay, what happens if we decrease by a drug this carbonic anhydrase? Well, we decrease the production of carbonic acid here. We decrease the production of acid here. So we decrease sodium proton exchange here. So less sodium is reabsorbed. So more sodium is in the luminal fluid and could get excreted. So that's another solute that could get excreted. And that's why diamox is a diuretic, because it's increasing the solute concentration, sodium bicarbonate, in the urine. More solute in the urine, more water in the urine, diuretic. Decreased production of bicarbonate, decreased reabsorption of bicarbonate, which is what we're trying to do. Okay? So this is the slide that informs you how to unpack carbonic anhydrase inhibition. Now I've done this to you on a problem set, so I could do something like this to you on an exam, but maybe throw a curveball and say, okay, this person has a genetic abnormality with higher than normal expression of carbonic anhydrase, a mutant carbonic anhydrase. What is that person's superpower? What is the phenotype of a person who has higher than normal, bless you, higher than normal expression of carbonic anhydrase, both cytoplasmic and, say, apical? That I could do that. I'm not sure I know the answer yet, but we could figure it out. Okay, potassium was complicated. The main thing about potassium is that, so when I asked you about potassium wasting, most of you got at least part of the answer. Most of you said, okay, the drug, the diuretic that inhibits this guy, the loop diuretic, like Lasix, inhibits this transporter. So the reabsorption of sodium is inhibited. More sodium diuresis, more water diuresis, that's good. And you also understood, okay, if we inhibit this, less potassium reabsorption, more potassium diuresis, potassium excretion, potassium wasting. That is a legitimate answer. But in addition, okay, so that is a legitimate answer. But in addition to that, if we have decreased sodium reabsorption here in the ascending loop of Henle, then we have more sodium being delivered to the collecting tubule, and we have more sodium-potassium exchange going on in the collecting tubule, which leads to more potassium wasting. And that's why that inhibiting this transporter, that's another reason why inhibiting this transporter could lead to potassium wasting. More sodium-potassium exchange in the collecting tubule. Amiloride is a diuretic because it blocks sodium reabsorption here. So more sodium in the urine, diuresis. Blocking this blocks this exchange. So we have sodium excretion without potassium wasting. And that makes amiloride a little bit better for some patients. The loop diuretics that block this transporter are powerful. They cause rapid, dramatic diuresis. The amiloride is gentler, less effective, but doesn't have the side effect of potassium wasting.
Could you ask us that, like, on the exam based on those?
Like, which is more, like, ask you a pharmacology question, which is a stronger diuretic? No, I would not do that. Okay. That's pharmacology. Unless you want me to. Okay, loop of Henle, vasorecta, countercurrent multiplier in the setting of a hydrated person producing a dilute urine. Is vasopressin high or low? Wow, it says it low. So I should have blanked out the title. Low vasopressin, low angiotensin, low aldosterone. Low vasopressin makes for low water reabsorption here, so high water excretion. Low aldosterone means low expression of the sodium-potassium 2-chloride cotransporter, so low countercurrent multiplier effect, so low solute gradient, so less solute gradient that any water permeability has to work with here to pull water out of urine. Less water reabsorption, more water excretion. A dehydrated person, more vasopressin, more vasopressin-dependent expression of aquaporin by the GS story that I feel completely entitled to ask you about. Vasopressin, aquaporin, water permeability is high. Water is extracted from the urinary fluid, producing a highly concentrated urine, which has low water concentration, low water excretion. High expression of aldosterone, downstream from angiotensin II. Lots of the expression, high expression of the sodium potassium 2-chloride, the cotransporter, high activity of the countercurrent multiplier function, creation of a very high solute gradient, so more solute being used by the vasopressin-dependent water permeability here to pull water out of the urinary fluid. I mean, what I just did in a minute is something that will take you many minutes to figure out. Questions about countercurrent multiplier, the proteins that are important in it, where there is solute transport, and where there is water permeability, where there is water permeability and not water permeability, where there is vasopressin-dependent water permeability. Happy to answer questions. The countercurrent multiplier story. A bunch of clickers about control. No, these aren't clickers, a bunch of slides about control. I don't think I printed them out for you. Why don't we, let's take a break. You can review what we've done, sort of whirlwind review just now. And then I've got a bunch of clickers that we can use to trigger conversation. Let's do that. Let's take a short break now. Head injury, concussion, sometimes damages the posterior pituitary. Not typically, not commonly, but it can happen. It's not usually a concussion. This is a real head injury, a car accident sort of head injury. What would be the effect of a damaged posterior pituitary with decreased vasopressin release on urine production? This is hard. It's something I almost know. Let's walk through this. Inability to produce vasopressin. So no matter how dehydrated this person is, they're not producing vasopressin. So they're producing a dilute urine all the time. Right? This story doesn't happen, ever. No vasopressin, no story, no low aquaporin expression. Oops, sorry. Always low vasopressin expression, always producing a dilute urine. Right? This is low vasopressin. That's what we've got going all the time. No matter how dehydrated this person is, they're not producing vasopressin because their posterior pituitary can't or doesn't. Okay, does that make sense then? Low vasopressin. Dilute urine. Large volume of dilute urine. They would become dehydrated pretty quickly. And this happens. I mean, there's a clinical case of somebody with a head injury and posterior pituitary damage where they, at night, they had to get up every hour at night to pee. And, by morning, they were dehydrated because they weren't drinking enough, they weren't on IV fluids. And so, this disease has a name. It's called diabetes insipidus. So it's diabetes because it's producing a lot of urine, which is what diabetes mellitus does as well, because of all that glucose. Diabetes, but it's not mellitus. It's not a glucose thing. It's not glucose, so it's not diabetes mellitus, it's diabetes insipidus. High production of urine, dilute urine all the time, tendency to dehydrate if you're not drinking all the time. You can go into low sodium, you can have excess sodium excretion and get sodium imbalance. And the treatment is a nasal vasopressin. There is a drug, nasopressin or something. Anyway, it's a nasal spray of vasopressin that circulates and becomes artificial vasopressin. Okay, so I'm not going to ask you pharmacology in the sense of, I wouldn't ask you what is diabetes insipidus. But if I gave you this, information, I might enough information for you to figure out the physiology. I might ask you a question along these lines. What would be the effect of too much vasopressin? A tumor, a pituitary tumor, right? Okay, here's a tumor question. Adrenal tumor. This isn't a pituitary tumor. This is an adrenal tumor. Adrenal adenoma is usually what it is. Can cause adrenal cortex to produce too much aldosterone. In cancer, a aldosterone-producing tumor. Obviously not normal. What would be some of the symptoms of this tumor, adenoma? These are hard. Pharmacology is hard. I used to teach pharmacology once. It's hard to teach. Because you want to teach mechanism. There's so many drugs, you have to cover so many drugs, and each drug has got its own sort of side effects that are slightly different from other drugs, and so you've got to teach both the mechanisms and then these strange, like, idiosyncratic side effects. It's really hard to teach. Okay, so I'm seeing some of the correct answers. So some of you have this answer correct. Michael, you have this correct. Why B? Why is B correct? I'm putting you on the spot.
The kidney would reabsorb more fluid, and therefore blood would have more volume. And
Exactly.
that would increase
So
presence.
C happens because aldosterone is part of the mechanism for increased sodium reabsorption and water reabsorption. Acting where? Where is aldosterone acting? On the loop. What protein is it acting on? It's the sodium potassium 2-chloride cotransporter expression. Increased expression of that transporter, increased countercurrent multiplier, increased sodium reabsorption. Increased water reabsorption because we're building that solute gradient higher than we need to. So increased sodium and water reabsorption would increase blood volume and blood pressure. Okay, and you also, somebody over here, Joyce, I think you got this one right. Why did you choose D as a correct answer?
I don't remember what a HO answer is.
Yeah, and I would never ask you this because this is one of those things that I said, let's just go past it, but we didn't quite go past it, but now we're coming back to it.
But I'm just thinking that if everything is being absorbed around, then it must absorb and then going back to the blood and then going to the.
Okay, so that's not quite the right answer. Michael?
Doesn't AMP, isn't it one of the few mechanisms that lowers blood pressure and volume? Like it expels sodium?
It does, right? So the effect of AMP is to increase, so AMP stands for atrial natriuretic protein, so a protein that increases sodium excretion. So that might be an attempt by the body to increase sodium excretion when the tumor was increasing sodium reabsorption. So that is a correct way to think about it. What is the stimulus for atrial, hint, natriuretic protein secretion? Atrial stretch, increased blood volume, increased atrial stretch, increased production of AMP as an attempt to compensate, not effective usually because it's not that strong an effect, but you would see, if you did an endocrine test on blood, you would see elevated circulating AMP. They can do, an assay for hormones in the blood, including AMP. Okay, so that's asking you to know something that I wouldn't do this on the exam because it's this one, part D, I wouldn't do on the exam because it's asking you to remember something that I kind of minimize the impact of, and it's probably not on the key concepts list either. But B and C certainly I could do because it's integrating what you know about the kidneys with what you know about the heart. And there is some fact here that maybe I didn't integrate, but now I am. Increasing blood volume increases blood pressure. I think we may have touched on that in the cardiovascular section, but now I'm emphasizing it. Okay, let's do another one. Another drug. Inhibitors of ACE inhibitors can cause which of these effects? ACE inhibitor. Now you have to think about, okay, where is ACE and what is it? Now, so you know we had ACE up on the board, ACE inhibitors up on the board. Oh, no, we had thiamox up on the board. Now we're talking about angiotensin converting enzyme inhibitors. What does, so maybe the ancillary question is, well, no, what do these do? Again, this is pharmacology, which makes it hard by definition. Let's see. I think it's going to cause all. Okay, let's walk through this one. Angiotensin is a vasoconstrictor. So angiotensin converting enzymes, low angiotensin because it's not getting converted from angiotensin 1. The enzyme inhibiting the enzyme that produces it makes less of it, less vasoconstriction, vasodilation. That's the logic. There's the logical flow in that case. Vasodilation, low systemic vascular resistance. Now I'm asking you to remember an equation. Somebody tell me the equation I have in my head right now. Over here on the right side of the equation is systemic vascular resistance. What's on the right side? Cardiovascular. No, not on the right. Not over here yet. Not if we have resistance over on the right side. There it is. Mean arterial pressure is equal to cardiac output times systemic vascular resistance. Cardiac output, stroke volume times heart rate. Increasing resistance increases blood pressure. Decreasing resistance decreases blood pressure, which is why that's a correct answer. And ACE inhibitors are used to treat hypertension, chronic blood pressure, chronic high blood pressure. Okay? Decreased GFR. This one's a little tricky. Low blood pressure, low filtration pressure, low filtration. That's the easy way to get there. Vasodilation of the efferent arteriole, low filtration pressure, low filtration. If you get sidetracked into saying, okay, vasodilation of the afferent arteriole is going to lead to an increased GFR, that's good thinking, but it's just not right. Okay. So that's why I would not ask you this question, because I want to evaluate your thinking and your application of knowledge that you have, not application of knowledge that you don't have. That's not a fair question. So, why would we get reduced aldosterone?
Angiotensin 2, which would be made from angiotensin 1 being converted by ACE, is stimulated by, like, aldosterone release is stimulated by angiotensin 2.
Right. The name of this pathway is the renin angiotensin aldosterone axis, RAA axis. If we break this here, we decrease this here. That's the way to think about that. Okay? Are we good with that? Got a lot of groans when I show the answer, but that's kind of the point. I think this might be the last one, so let's go through this. At high concentrations, caffeine is an inhibitor of cyclic AMP phosphodiesterase, PDE. Oh, this isn't a clicker. This is what are some of the effects of caffeine at high concentrations? Acting as an inhibitor of phosphodiesterase. Now, some pharmacologists would say, Bob, that dose of caffeine is fatal. Don't go there. That's not pharmacology. But it's still a useful teaching exercise. Caffeine at high concentrations is a phosphodiesterase inhibitor. So what are some of the effects? Some of these you probably know from personal experience and experimentation. What are some of the effects of caffeine? Not a fatal dose of caffeine, but a high dose of caffeine. Say again?
High levels of
High levels of cyclic AMP. Okay, fine. We're going to have high levels of cyclic AMP because we're inhibiting the enzyme that breaks it down. Okay, that's a now. But I want to get to some physiology. That's biochemistry. Now I want to get to some physiology. What are some of the effects of high chronic cellular cyclic AMP? Increased diuresis. Okay, yeah, you probably have experienced that. That's true. Why? What are some of the other effects of caffeine? Increased aquaporin. Is that going to cause increased diuresis? That would work. That would go the wrong way. So you're right. I can see what you're thinking. You're remembering. Well, you're remembering this slide. And you're saying, okay, if we have high cyclic AMP, we have high of this, but that's going to lead us astray because that's not the effect. The effect of cyclic AMP in the kidney is diuresis. So that's going to be a confounding effect, and that happens all the time in pharmacology. What happens to your heart?
Increased heart rate.
Increased heart rate. What happens to your stroke volume? Increased stroke volume. Increased stroke volume, increased heart rate. What happens to your resistance? Think what happens in the norepinephrine. Increased resistance. Cyclic AMP activates pKa, which increases calcium flow in smooth muscle, which increases resistance. In any case, even if we didn't get there, we got this, that's pretty easy, right? This is acting on heart rate, what cells are important in the heart rate? SA node, sinoatrial node. What cells are important in stroke volume? Cardiac muscle, ventricular myocytes, right? So, right, I could start integrating this. This is where the end of this course is going. And that's where we're going. So we're going to increase blood pressure. Caffeine increases blood pressure. That's a well-known effect. So increasing blood pressure, what would that do to GFR? Increased GFR is the mechanism for diuresis. The effect on the cortical and the medullary collecting tubule is a confounding effect. So high heart rate, high blood pressure, diuresis, increased water absorption, but that's confounding because we have high diuresis. Yeah.
Can you just go over like because you just said like the effect of norepinephrine when it attaches to the alpha adrenergic receptor is a GS?
Well, no, the alpha adrenergic receptor is GQ. So that, but, yes, so it is GQ. But, I see what you're saying. So GS could be vasodilating and
Well, I'm just thinking more, look at like, you were just talking about how like CAMP plays into like norepinephrine and I just don't understand.
maybe I misspoke.
Okay.
Okay, so let's fix that. This is not gonna happen. I'd have to look it up to see whether there are systems in which cyclic AMP increases constriction. The classic story is norepinephrine acting on alpha adrenergic receptors, which is as Brittany said, GQ. That's the story I want you to know. But we also know that beta adrenergic receptors is a GS story, a cyclic AMP story, and that would increase. You drink coffee, your heart beats faster, it beats stronger, and that increases blood pressure. Okay, so let's stop here. Remember